Good morning friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist I have provided almost all the topics in a very systematic order and this is quite convenient for the study. I hope you will make use of it. My dear friends, we have been discussing about hemophilia. In the last class we have seen some of the basic information regarding hemophilia and we have also seen the different types of hemophilia and the inheritance associated with that. We have seen the X inactivation, a very typical phenomena, and today we shall have pathogenesis related to this hemophilia. We need to discuss the pathogenesis. Now, why actually in hemophilia there will be bleeding? So, suppose if you take an artery, that is vessel, that vessel is covered by the innermost layer, that is in the lumen. So that is endothelial lining or endothelial cells will be there. Now this cell contains the collagen. These endothelial cells, they also contains a collagen which is also called as von Willebrand factors, which is present in the subendothelial collagen. Now this endothelial cell layer, it contains the collagen tissue. In the subendothelial collagen, we will have collagen which is in the layer of the subendothelial collagen layer. We have the collagen by name factor which is called as von Willebrand factor. So when there is endothelial injury, this subendothelial collagen which is containing the von Willebrand factor is get exposed and now it will start attracting the platelets and von Willebrand factors are gets attached to the platelets. Okay. So this attachment is made possible by using a glycoprotein which is called as GP1B, glycoprotein 1B, which is present on the surface of the platelets. The surface of the platelets, they contain a glycoprotein by name GP1B. Now these von Willebrand factors which are released from the subendothelial collagen, so they will going to attach with the platelets. And as we know, this process is called as platelets adhesion. Okay, so when this combine together, it attaches to when the von Willebrand factor collagen attaches to the GP1B present in the platelet, the process is called as adhesion. So now in this case, von Willebrand factor will work as a bridging factor. Now very important, the von Willebrand factor will work as a bridging factor. So in the absence of the von Willebrand factor, so this adhesion will not take place. Although it's a very simple factor, so that is very much required for this adhesion. So this leads to, once this adhesion takes place, then it leads to the activation of the platelets and more and more platelets will come to the spot and they will use the fibrin through the GP2B which is present there to attach more platelets to the sites. So this is called as platelet aggregation. Of course in the first class we have seen all these things but not in detail. So this is called as platelet aggregation and this is called as primary hemostasis. That means once there is platelets adhesion takes place, then it leads to the activation of the platelets and as a result more and more platelets will come to the spot and now they will use this fibrin through the GP2B, another protein which is present there to attach more platelets to the site. So this is called as platelet aggregation and this is responsible for formation of primary hemostasis. But this bonding is very unstable, as we know, discussed already. In order to make this platelets plug more stable, we need many clotting factors which activates in the series, including factor 8 and factor 9. So now comes the role of the clotting factor to make it a stronger bond, and at the end there is formation of the fibrin and fibrinogen is converted into fibrin, and this fibrin just like a meshes, it get deposit over the primary hemostatic area and a permanent coagulation plug will be formed. So we know that the intrinsic pathway is there, extrinsic pathway is there. In the intrinsic pathway, we will have 12th factor, 11th factor, 9, 8 and 10th factor. Whereas in the extrinsic pathway, we have got more commonly 3, 4, 6 and it starts from the 7th, activation of the 7th and then 10 and then 3 etc. 3, 1, 2 etc. And the common pathway, yes, we have got the common pathway that is 10, 5, second and 1. So this pathway are mediated through the calcium ion. We know that the intrinsic and extrinsic pathway both are possible only in the presence of the calcium ion and parathyroid hormone. So by this we can get an idea that does the defect in the intrinsic pathway or extrinsic pathway, that means by this we will get an idea that if there is a defect in the intrinsic pathway or extrinsic pathway, definitely there will be prolonged bleeding. Okay, so as we discussed already, in the extrinsic pathway, it is the prothrombin time which is increased, while in the intrinsic pathway, it is APTT which is increased. So this portion already we have covered. Now talking about the clinical symptoms of hemophilia. Now neither the factor 8 or 9 will cross the placenta in the intrauterine period. This is very important information. So from the mother, factor 8 and factor 9 will not cross the placenta. So baby may start with the bleeding immediately after the birth or in the fetus also. Suppose if the child has got hemophilia, that particular gene is absent or whatever X-linked recessive trait is there, then even the baby may start bleeding in the uterine life itself, because factor 8 and factor 9, if the baby is not able to produce, then at least it should come from the mother's side. But unfortunately through the placenta, mother's factor 8 and 9 will also not cross the placenta. So baby may start bleeding in the intrauterine period itself or in the fetal life itself. The main symptom is bleeding after a trauma which persists for minutes to hours or at times days together. So there will not be any immediate rapid bleeding takes place in case of hemophilia. In hemophilia there is always a slow bleeding, but for a prolonged time. Slow bleeding for a prolonged time it will take place. So there will be most of the time, that means in trauma etc. there will be rapid bleeding in. But in case of hemophilia it is not like that. It is always a slow bleeding, gradually it is taking place, and it takes place inside the body. Most of the time the formation of hemoarthrosis, or there will be hematomas. Okay, and bruising will be there at the area of the trauma after 1 or 2 days. Now there will be joint bleeding, which is very common because joint is a pressure sustaining area, and as a result there may be hemoarthrosis, especially in the knees, elbow, shoulder, hip, etc. Now earliest joint which actually get affected is ankle joint in children, but in the older children it may be knee joint or elbow joint. Now warm tingling sensation in the joint is a first sign of early joint hemorrhage. Okay, suppose the child is playing, he has got a mild injury. Okay, that may be sufficient to initiate this process, and by 1 or 2 days there will be collection of the blood in the free area. So because of slow bleeding which is taking place, and later there will be formation of the hemoarthrosis, or what you say, hemorrhage. So after repeated bleeding episodes of the same joint, there will be development of the target joint. When the same bleeding takes place in the same joint for a number of times, so then that joint is always more prone to develop the hemoarthrosis or get affected by the hemophilia. We will call that joint as usually a target joint. Target joint. Babies may bite the gums and teeth. It may also lead to bleeding for a longer time if the child is suffering from hemophilia. Bleeding while tooth brushing is also possible. Gum bleeding will be seen while the child is tooth brushing. One more important thing is epistaxis is also quite common. Epistaxis is also quite common. More commonly, when you are cutting the umbilical cord, at times you will get a finding that the bleeding is not stopped immediately. Usually when you cut the umbilical cord, bleeding will going to stop. Sometimes it may not stop, or there may be recurrent bleeding from the umbilical stump area after the falling of the umbilical cord. Further, some of the important symptoms are bleeding for a longer time may be there after tooth extraction. Most commonly, this is the way how it is identified. After the tooth extraction, maybe the temporary it is sometime, the bleeding is not stopping, then we will have a suspicion. Sometimes GIT bleeding may also takes place. It may lead to melena and also hematemesis. Easily bruising, this is commonly seen. So if you touch, you put some pressure, compression, so there will be bruising. Okay, this is one more important thing. Area fatigue. Fatigue may be there due to anemia. Because of the bleeding, there will be anemia. Bleeding into the open space, that means tissue spaces. So blood is coming out of the RBC is coming out of the vessels, so that leads to anemia. Now at times there will be bleeding from the muscles and as well as soft tissues. Very common in the iliopsoas muscle, which is present around the hip. And this leads to hip joint remain flexed internally rotated position due to irritation by the iliopsoas muscle, and diagnosis is made clinically by inability to extend the hip. Okay, see, this is how usually the diagnosis, different ways of diagnosis according to the symptoms. Okay, usually bleeding may also take place in the muscles and soft tissues in the hip area. The most common area is iliopsoas area, muscle area. Okay, so when there is bleeding around the iliopsoas muscle area, because of the irritation, what actually happens is the hip joint remains flexed, internally rotated, flexed and as well as internal rotated position because of this irritation. So that makes the person difficulty in extending the hip. He is not able to extend the hip. So he will be either in the sitting position only or in the sleeping position only. So this is confirmed by USG and CT scan. Now one more spectrum of the symptom is intracranial hemorrhage, which is quite dangerous, and oropharyngeal, then periventricular bleeding are also present. So clinical severity of the hemophilia correlate with the level of deficiency of the clotting factor. How much is the level of deficiency of the clotting factors? Depending upon that, okay, it will be there. So in hemophilia A, if the level of the clotting factor 8 are less than 1% from the normal level, then the symptoms will be very severe. In hemophilia A, classical hemophilia or true hemophilia, factor number 8, if the level of the clotting factor 8 is less than 1%, it should be 100%, if less than 1% from the normal. Okay, what is the normal value is there for the factor 8? If it is less than 1%, so then the symptoms will be very severe. You can identify. Okay, now you can understand the severity. If it is less than 2 to 5% than the normal, then it will be moderate, and if more than this, it may lead to the mild form. Now these are some of the areas where hemoarthrosis takes place, and this is how the second picture, petechiae and purpura and hematomas usually develop. This is also one hemoarthrotic condition in the knee joint. So you can see here also the hemoarthrosis, hematoma formation, and these are the different areas where usually the hematomas are formed. These are in the second picture in the gluteal area. You can find again a big hematoma. Now let us discuss the lab finding related to this hemophilia. Now looking into the lab finding, bleeding time will be prolonged in severe cases only. Okay, the prothrombin time will be normal, as this is the problem, as this is not the problem of extrinsic pathway. If it is extrinsic pathway, definitely prothrombin time will be raised, but this is not a prothrombin problem. It is not extrinsic pathway. So definitely the intrinsic pathway is affected, so there is increase in the partial thromboplastin time, that is APTT or PTPT, but it is called by both names. Okay, activated partial prothrombin time, APTT, that is raised. So usually it is increased more than 2 to 3 times, okay, than the upper level of the normal limit. Factor 8 SA factor and factor 8 SA and factor 9 SA is very important, because of these are the two important factors which leads to hemophilia, to identify either the classical or factor 9 hemophilia. So in hemophilia, lab finding we will have bleeding time is normal because extrinsic pathway is normal, meantime platelets are also normal. Therefore, the bleeding time will be normal, but clotting time is increased, especially APTT, that is intrinsic pathway, and prothrombin time is normal because it is related to extrinsic pathway. Now all the other screening tests except APTT is normal. If you see all the other things, everything will be normal except APTT. Okay. Now mixing test is also normal, because mixing test means you will have extrinsic and intrinsic both. So if there is a problem in the intrinsic also, extrinsic will going to manage it. Okay. Then quantitative Bexeter test, SA may be done. So to measure the antibody titer, if there is inhibitors etc. is there, so you can go for that. Now we look into the treatment. Decompression acetate release the factor 8 from the storage. One of the drug which is used is a decompression acetate method. So this actually helps to release the factor 8 from the storage. In the storage, if there is a collection of the factor 8, that will be released into the blood. Then definitely we have to go for fresh frozen plasma. Then we have to supplement the recombinant factors 8 and factor 9. Then we need to avoid contact sports in the child. Okay, we should try to avoid the injuries as far as possible. Use the soft brush. Then avoid medication like aspirin, antiplatelet, any other drug which is having antiplatelet activity. Best play for that this particular child is swimming, because in the swimming the risk of the injury is less compared to any other, because it's not a hard surface. So risk of injury is less. Vaccination against hepatitis B is very important to protect the liver, because clotting factors are released from the liver. Next we discuss about the complications of untreated case of hemophilia. If the hemophilia is not treated for its complication, what can happen? In the joint there may be hemoarthrosis, pain and deformity. There may be damage to the muscle. Then compartment syndrome. This is a syndrome called as compartment syndrome, that is bleeding inside the muscle layer and the compression of the artery and nerves. Then severe anemia and blood loss. Then bleeding bleeding from the urinary tract leading to hematuria. Then clots obstructed in the urinary tract leading to painful micturition, and most dangerously intracranial bleeding. Some of the chronic complication, chronic arthropathy due to recurrent bleeding in the same joint, which is called as target joint, may lead to Charcot's joints, and risk of transfusion transmitted infections, because we have to go for recurrent or repeated blood transfusions etc. So it may lead to transfusion transmitted infections. Then there is development of inhibition. Talking about the prognosis, if the diagnosis and treatment was done properly, then prognosis is good. You identify the clotting factor deficiency and go on, keep on supplementing it periodically, then it is good. Improper treatment can lead to worst prognosis, no doubt. Sometimes inhibitory substances are formed against the recombinant factors. Unfortunately, sometimes when you give factor 8 and factor 9 from the outside, body produce some inhibitant or inhibitory substances against it, thinking that this is a foreign material. This is one of the unfortunate thing, and this may lead to problems. And rest of the things related to this, there are some more information and some of the case studies we will have. So that we will discuss in the next class. Thank you very much.